When we talk about really expanding it, as Erin said, this is not easy. It's not quick. And when you're talking about, the aging population, there's a lot of nuances there around, the children, worried about aging parents. We tend to really stop being person-centered in that regard, and I say we because I'm dealing with an aging parent. And certainly with the disability population at large, it's just so important to keep that focus. And our Medicaid agency, as Erin mentioned, when you get into the elder and person with disability waiver arena in many states, it's a medical model. It's the doctor develops a care plan, it's signed by a doctor and nurses, and it's a PCA, and it's not really thinking about how do I continue to support the person, be they elderly or a person with a disability, to continue to have a good life. It's simply how do I keep their ADLs going or keep them healthy. So it really takes a very long-term effort, and it's really about infusing those values and changing the conversations. Supporting HCBS and Olmstead compliance, you don't think about so much the values, how values support Olmstead compliance and HCBS compliance, but really without values, that's really what pushes that compliance issue, because if you simply say, go forth and follow those rules, it doesn't happen. And believe me, the district in the last 8 years is one of the most regulatory compliant places in the country, trying to get out of our litigation. It's really been more about infusing values and changing how people think about people and think about the services and supports that really has started to change how people think about choice and control and rights and decision making. And if you're not going to have some of those rights and control, really having to defend that in the person-centered plan per the HCBA regulations. So it's really critical to change that thinking. And certainly, certainly having people with valued outcomes integrated in their communities, inclusive lives, employment, getting people services and supports when they need it, that's really what's important. And I speak often about, the realities of how many people don't have services in our system, particularly in DD, with hundreds of thousands of people waiting for services. But I'm sure across the service delivery spectrum, the country can't afford it. We all know what the challenges are in Medicaid and social services. So really thinking about, if you do good person-centered thinking and life course planning and integrating all of our resources in the community, it just helps people have a much better life, and it's much more realistic in terms of our long-term services system. So I think we're going to open it up to questions. The challenges and opportunities certainly is that building that buy-in from naysayers and people who perhaps don't share that vision and value. Bringing it to scale, as we talked about, is not easy. So that's why this is a multi-year effort. Cultural and linguistic competency, I won't go into it, but it's clearly something you have to tackle no matter the jurisdiction. Sustaining your family and self-advocacy engagement. One of the things we did early on was put stipends into our statute. If you want to include people and not have them go to work or really value their participation, it's a job. You have to pay them. And so we pay people when they participate in our communities of practice or do training or do whatever they do. They're paid, they have child support and transportation support. And then for any government, as you know, navigating competing demands, and there are a lot of them, particularly in the states where they're experiencing a lot of loss of personnel, as are the federal government, I'm sure. But there's a lot of brain drain, there's a lot of resource drain in government, and there are a lot of demands being placed on long-term systems and services and supports, not the least of which are coming from CMS. You know, it's really hard to put forward really significant systems change and find that time, find that leadership commitment when you have a lot of competing demands, so both local and national. So I'm not saying this is easy. This was a long, hard road that Erin did a lot of the work. But I can also step back and say that it works. And one of the reasons why, as Erin just shared yesterday, we participate in the National Core Indicators, which is used not only in developmental disabilities, but also now in the aging and disability communities for the states. And it's an outcome-based indicator survey that you can use to measure yourself over time, the state, and then also compare yourself to other states and nationally. And we just got back the results, and Erin shared that our performance measures, actual measures, have gone up significantly in employment, in people who want to be employed, and in other person-centered measures, indicators, and outcomes that we've been tracking now since 2009. You know, having some real evidence that in fact works. So it's not just talk, it's actual outcomes. So questions, we're welcome to take some questions or comments, any of us, from your community.
My name is Karina Stiles, and I'm with the Independent Living Programs here at ACL. And I have a question referring back to around slide 17, where you were talking about the person-centered thinking and the HCBS waiver and regulations. And I think it was Erin that talked about the progress note prompts that were created, and I see some transferability there with the independent living plans that are required at the centers for consumers. And I'm wondering if you could talk a little bit more about that and how you got buy-in. I guess it would be buy-in from the various agencies to use the prompts, and if they're available to just look at and see if that might be something that could be transferable.
Yeah, so we built them right into our regulations, and our process for rewriting our regulations, as I said, was part of our home and community-based settings rule compliance. But we brought together, when we did that, not just our staff and our person-centered thinking leaders, but our supporting families community of practice, our providers, our P&A, our DD council, our USED, and Project Action was in the room with us. And so we had a robust group looking at this with us. And we thought, if we're going down a person-centered journey, we have to move away from progress notes that say things like, checked on person still breathing over the night, right? Like, why are we documenting that? Of course they're still breathing, We wanted notes that were more meaningful. And so the providers actually had pretty strong buy-in with the idea that, their fear in writing different notes was that they would get dinged in monitoring because they were afraid they weren't meeting our expectations and what we were looking for. So as long as we were clear in our regulations about what we expected to see, and particularly around community engagement, we'd see things, our old notes would say something like, person went to the store, they were there for 15 minutes, there was no incident, and then they returned to the van. And it didn't tell us anything meaningful about the activity. Was it something they liked? What did they do there? What did they get from it? What was hard from them? What might we want to try again? And so once we gave them permission to start writing things differently, they were happy to do that. And so that's where we started, was just with the daily progress notes, with the idea being that given the turnover in the field with direct support professionals, those are the folks who are closest to people we support, and we lose so much learning every time they turn over. And so if our progress notes, particularly around community interactions and inclusion activities, were more robust and more meaningful, we'd have a better chance of not losing that learning, particularly for people who aren't able to speak for themselves and communicate what it was that they like to do. And so that's where we started. Another thing we've done in DC is we've developed a statewide person-centered thinking learning community. It's kind of cool. It's the first one where we've just expanded it across long-term services and supports. We started the first 6 to 8 months was just DD, and we've had new person-centered thinking trainers expanded it across our system. But one of the things that came out of our learning community was a request for our quarterly reports to use person-centered thinking prompts as well. And so what they suggested was there's a person-centered thinking tool called the 4+1. And they asked that they be able to use that tool to report back. And it asks, like, what did you try? What went well about it? What are you concerned about? What are you going to do next? And it's a very different kind of reporting. And so for that, we didn't mandate the 4+1 tool, but we put in our regulations that it was an acceptable model for reporting, and that we would like quarterly reports to address those 5 questions. And so you don't have to use that particular form, but you do have to answer those inquiries as part of your quarterly reporting. And so we'd be happy to share those. Thank you.
And then we'll take one from the chat. I'm going to bounce back and forth between this and the chat so I can see the questions, but if you want to go ahead, Lori.
This is terrific, and thank you very much. I'm Lori Gerhardt. I work in our Office of Consumer Access and Self-Determination. And one of the questions that oftentimes we hear from states as they're doing their transformation to practice more person-centered thinking and planning and counseling is to how do they get leadership to buy in? So can you talk a little bit more about how you went about that process? What seemed to be the things that really got leadership interested in making this cultural shift?
Well, let's see. Well, I was the leader in DDS, so I didn't have to get myself to buy in. But I'll tell you, but I bought in the sense that, for me, I was seeing a system where I was doing a lot of systems change of a system that wasn't working well. And so we were putting in a lot of structural elements into a system. So it was training, it was a new Medicaid program, new rate methodologies, new quality assurance systems, new performance management, and you get so far and and then you hit this wall. So for one thing is that, there really is a communication about there is only so far you can go with a regulatory or a hammer or a prescription in terms of really getting to the kind of outcomes that you're trying to achieve. And now particularly with your HCBS settings requirements, you're going to have to really look to a different strategy to really get people to think differently if we're going to make this change. In terms of getting that buy-in then across LTSS and across the system at large, I can kind of not quote exactly, but from the executive office of the mayor, what frustrated the new administration was a system that was fairly well financed, that had a broad array of services and supports from aging, from the waiver programs, behavioral health, and an excellent healthcare program. I think, if you don't know, the vast majority, 99%, 97% of the district residents are covered by health insurance. So a very rich system in that regard. And yet the executive office and probably directors at departments were hearing a lot of negative feedback about their system, about their respective services. And so the executive office of the mayor, as they continued to talk with our department about what we were doing, and we had an entree because of some of the significance that we were working on with our court case, really began to understand and see how this made sense to them. Of course you'd want to be responsive. Of course you'd want to use community resources. Of course you'd want to listen to people that you're serving and help them become more productive members of our community. And so I think it's really a matter of trying to help leadership understand that it's a tool in the toolbox and one that is going to have surprising results for you. I think that maybe could be one of those things that if we can show people what some of the benefits of it. I was talking yesterday on a ODEP call in Employment First, and one of the things that was briefly talked about is they have put out a structure for how systems change in the Employment First, and how maybe we need to do the same in person-centered thinking. What are the elements at a provider level and at a system level to make sure that you're actually becoming a person-centered thinking of provider and system, since we already have that framework at the federal level. So it's not easy, and leadership is not always has those values, depending on the kind of political appointments you have. But I think maybe if we can communicate that the benefits better, what the outputs are, we might be able to use it as a tool.
Okay, a question from the chat. Have there been barriers, or is there a strategy that you have for working to infuse services for older adults?
I saw that
Did you see that?
question
Okay.
as well,
Oh, good. All
about
right.
how does this apply to the aging or older adult community. And when Erin was speaking, she often said ADRC. I think that's because we engage so much. But the DC Office of Aging is actually a very strong partner in this, not just the ADRC. And certainly with aging, again, the same principles apply, and I think, we get, again, too caught up with, just supporting older adults, particularly in the AAA area, about meals, about transportation, about adult day health, keeping people healthy, helping them with their ADLs, helping with transportation. If you think about where we started with Erin, people come in, we focused on an eligibility and what service do you need. The AAA and everybody else does the same thing, and I'm not knocking it. It's how government works. But if we, again, reframe that picture about what does that older adult need to continue to be safe and happy in their community, in their home perhaps, and stepping back rather than plugging in a service, thinking about what are their goals. And, we often don't talk about goals for older adults. We think about service needs. But they have goals too, if you turn it around. I want to stay as healthy as I can for as long as I can. I want to be able to continue to engage with my friends and go to my local church. I want to be able to stay in my home. So if you switch that framework and then start looking at, I want to continue to be happy, I want to see my family, blah, that kind of stuff. and then start looking at, rather than plugging in a service, what other supports are out there in your community, in your neighborhood, natural supports, generic supports, so that we stop just plugging in a service. And why I say this is the DD field has learned a long time ago, the more service you put on a person, the less involved they are in the community. And oftentimes, the less safe they are. Services create barriers. And the same is true with aging. If you wrap around a person, an older person, if you wrap around PCA, around that person, then they're less likely to be engaged in their natural community, less likely to have more people who see them on a regular basis, more at risk of being taken advantage of, less likely to maintain their relationships. You have to, think about it in a broader context. And I really do think that if we embrace the same kind of principles, it's not going to look identical, but if you think about the principles and values in a similar way, I think you're going to have older adults having, again, that better life. Because I'll tell you, the more you wrap around paid supports, oftentimes the person's life is not going to be as good. They need to be integrated and continue. Paid supports need to play a supporting role. And the more you wrap around them, 100%, the less likely they are to have a good life.
Any other questions in the room? Okay, we have another one from the chat, and it's a question about responses from sort of the clinical side of the world to what you've been working on.
Do you want to talk about that, Erin? You dealt with the lawyers and the clinicians a lot. We went after them specifically. We did not ignore them.
Yeah, so we worked with Sport Development Associates to develop a couple of half-day person-centered thinking courses for our clinicians, for our lawyers, for our guardians, knowing that very often they were the barrier to people having a good life. And so we worked very closely with them. We've talked extensively with the attorneys about the home and community-based settings rule, about the requirements for person-centered planning. We have drilled into them that we believe the federal rule requires that they use supported decision-making in their representation with people, and that as guardians, they're responsible for making sure the person really has a strong voice in their plan. And so we've done a lot of work with them around that. And for the attorneys, seeing a federal rule, particularly a long one that they weren't interested in reading through all those pages. We just put up a couple of good quotes. I think was pretty effective at them understanding that this isn't just our idea and our values, but is really the legal requirement. For the clinicians, it's been really a challenge. It honestly has, and particularly with our behavior support clinicians, I'd say, more than, say, our physical therapists or speech therapists. It's a different model. It's a medical model. But as we've seen better results for people and we've been able to share stories, I think has probably been the thing that's been most effective. And so we have a number of cases where people who were in large congregate programs and had pretty intensive behavior support programs, as they've gotten into more individualized supports and have been out in the community, have been able to totally fade from their behavior support plans. And so as we've gotten better at person-centered thinking, we've stopped doing all of the things that are triggering people. And so clinicians are able to see some of those results, and I think that has really helped to be able to share some of those, real-life DC success stories.
I think the other thing with the clinicians, they're my pet peeve. Not, in a negative, but particularly in some paid service systems, we, for example, and particularly in one that's highly regulated like ours has been, we have, here's my favorite, we had over 50% of the waiver population in IDD had nutrition services. and they've had them for years. Now, I don't know about you, but I don't have a dietitian that works with me every month, every year, year in, year out, year in, year out, year in, year, and I just, like, why? And so it kind of goes back to what I said. We had gotten into this model of here's a plan, here's your needs, plug a service in. And so I started doing teaching with staff. I was getting so irate as the director, but, you know, and I would just show them. So the person needs to lose weight, and we want to do community integration, and they, you know, really need to learn how to purchase whatever. So they need to lose weight, and we're trying to push integration. And so, boop, nutrition. And I said, now how about that the person, the goal for the support provider is that the person is going to walk to the local store 3 times a week. They're going to learn, they're going to purchase healthy items for their diet, that they have gone to the local Y, and they've gone to a community nutrition class and learned about, and they're going to pay for it themselves and learn some money management, and they're going to walk home. One service, because they had somebody support them to do all that stuff. They didn't get fitness, nutrition, you know, residential support, and all the, it's like, what is wrong with people, you know? So, you know, it's just that kind of stuff. Do you have a dietitian and a PT and a, you know, people with significant disabilities? Sure. But folks with mild, moderate challenges, why aren't they going to the, you know, to the local health, you know, association, the Y, whatever. So, you know, it's that kind of stuff. Why didn't you go to the gym? Why do you need a PT to, you know, do your leg strengthening activities? So it's that kind of stuff.
Hold on a second. I just want to make quick. So this is going to be the last question. We're out of time, basically. But Scott, I think you have you're holding the mic, so go for it.
I have the mic. I'm Scott Corey. I'm the CIO for ACL. This has really been very interesting. I think one of the things that I find most appealing is that the work that you're doing is based in changes in people's behavior, changes in values, and very common sense approach to system change and integration. But this is a question about extensibility and transferability. Your approach worked really well in DC, where you had the ability to integrate with other city agencies and get buy-in. How does that approach that you were effective in implementing here transfer to other states or transfer to other cities where, you know, we're an ADRC? Because I think one of the things that and I've been involved with Lori and Joe in the No Wrong Door program, one of the things that we're really struggling with is how do you make this transferable and extensible? How do your practices turn out to be best practices for other people? Your
You
thoughts?
know, I say yes. The only difference from DC to other states is that we have a geographic density. But we are a city-state, you know. So we actually have kind of a more challenge to our work in that we have to deliver the service, and we have to be the state government structure, the planning, the policy, the interface with the federal government. You know, we got to do it all, and we got to deliver the service on the ground. So while we have an advantage just in geographic locality that we can go to a meeting, with today's technology, like we're doing here today, it's the same thing in a state. You have a governor, you have cabinet members, you have commissioners. Those people are the same as agency directors and mayor's executive cabinet. So if you have that leadership, which in a number of states you do, that drives that change, that directs the cabinet, that they're going to, you have, in some states, you just have giant departments of health and human services. A commissioner right there can do that. But it's the same principles. If you have that leadership to drive that kind of collaboration forward, and in an environment, again, I'm talking from a state, and not just one state. I have a national perspective from serving on national boards of states. The states are struggling desperately with finances, with efficiencies, with thousands of people needing supports. So there are a lot of governors out there that Health and Human Services eats up that budget, and so the right leadership, the right messaging, demonstration of outcomes. So ACL can show that jurisdictions that have done X, Y, Z, here are some of the measurable outcomes that can be translated into dollars, into their constituent satisfaction, into efficiency of government. It's that kind of stuff. So, I do, the district is not different than any other state, except that we don't have to use WebEx because we're geographically condensed. But we are a state in every other sense of the word. Behavioral health is a turf, Medicaid's a turf, Office of Aging is a turf, Disabilities a turf, and you need that certainly the leadership from your governor's office or your that cabinet leadership to do it. But CMS is a big stick, and the federal government is now working much better together across agencies in terms of that messaging. So I think you have the state's attentions. It's just keeping it going. And like I said, they have a lot of competing priorities. There's a lot going on out there.
Well, thank you. Thank you to Laura, Erin, and Stephen. Excellent. And thanks for the Assistant Secretary for Public Affairs for doing this great TV setup. It's really wonderful. And thanks to the No Wrong Door team and everybody for coming and listening and participating. And we will continue.
ACL, seriously, and AIDD, and we've benefited greatly from federal initiatives and really taken advantage of it. And so I would be remiss not to let at the federal level how important it is to that you're advancing a number of these initiatives, and states really, if they have the right stuff on the ground, they can really take advantage of it. So keep up the good work.
We'll keep pushing ourselves, so thank you. All right. Thank you. Thanks again.